Good day and welcome to Learning Thursdays. I am Dave Kruder, a trainer with the OASAS Learning and Development Unit and your host for this presentation. Today's presentation is part of our ethics series and is titled Year of Ethics, Favoritism and Specialty Treatment. The presenters are Tricia Allen, who is counsel in the OASAS Legal Counsel's Office, and Maria Passeri, who is the director of the OASAS Bureau of Addiction Treatment Centers. Learning Thursdays are offered to addiction professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals in prevention, treatment, and recovery services. A goal of Learning Thursdays is to support the educational and professional development of the treatment, prevention, and recovery workforce. We do this by offering monthly presentations that are relevant to today's substance use disorder treatment professional. As always, if there are any questions, comments, or suggestions, please feel free to contact us at the Learning Thursdays mailbox. You can use the same mailbox to express an interest in being a future Learning Thursdays presenter. At this time, I will turn it over to our presenters. Welcome, Trish and Maria.
Hello and welcome to our fourth installment of Year in Ethics. I'd like to welcome you to today's session. It is Favoritism and Specialty Treatment. My name is Tricia Allen. I am an attorney with OASAS Counsel's Office, and I am here with my colleague Maria Passeri.
Hi, I'm the director of the Bureau of Addiction Treatment Centers for OASAS.
So today we're going to run through a couple of items about favoritism and specialty treatment. But first, I'd like to remind you, if you have any questions, please feel free to send them to learningthursday@oasas.ny.gov. Okay, and now I'll turn it over to Maria.
Hi. This was a very interesting presentation that we put together, and I think there was some difficulties with some of the literature because a lot of the literature on favoritism had to deal with school children. But it took some time and we did some digging and we were able to find some specific literature about the clinic setting. And we developed 3 goals for this particular presentation. First one being understanding the difference and the definition of favoritism and bias, and understanding how facets of favoritism and bias can influence the counseling relationship. And last, identifying mechanisms to decrease the impact of favoritism and bias on the clinical environment. So if you take a look at the dictionary gives us some definitions. First being favoritism, the unfair practice of treating some people better than others. And in the treatment setting, what's really important is as our clients come into treatment, we find that we either really like them or we have some difficulty with them or they're not very likable. And so favoritism can appear in relation to both positive clinic settings and negative clinic settings. Bias, on the other hand, is a tendency to believe that some people, ideas, are better than others, and that usually result in treating people, some people, unfairly. So if we take a look at favoritism in the clinical environment, it's the tendency to offer unearned affection, benefits, gifts, opportunities to a person or group based on personal feelings. And one of the things that we know about our patients is they're paying attention to everything that's going on in the clinical setting. They're watching what kinds of things each person gets from the counselor and what they're not getting. So it's really important that as clinicians in the field or physicians or nurses that we pay attention to our feelings in the environment as well as what we plan on doing with our patients. So the effect really interferes with the fairness because it gives an undue advantage to someone without clinical justification for treatment. So there are many things we can do in the treatment setting, but we have to make sure there's clinical justification for the particular action that we're going to take. There are 4 determinants of favoritism, and one of the things about the determinants is that transference and countertransference is something that isn't necessarily visible to, in the actual practice of our programs. So it requires a counselor to have some insight, as well as it takes sometimes supervision and counseling to understand what's going on with those 2 determinants. And we're going to go into a little bit of detail as we move on in the presentation. The other 2, in-group favoritism and culture, are very interesting and have some basis for how we came to be on this earth and how we collected as groups. So a kind of a socialistic approach to understanding favoritism. Okay, so let's first take a look at the definition of transference before we move into how it interacts with favoritism and bias. It is feelings and issues from the past that patients transfer or project on the counselor in the current relationship. So, when patients interact with others, they're likely to respond in ways that repeat old patterns from their past. So let's take a look at our patients' relationships with their parents. Let's say their parents are very enabling. So in the relationship then with you, if you are nurturing in any way similar to the patient's parents, then we know that enabling parents tend to give everything they possibly can to their son or daughter. So in the treatment setting, what happens is the patient will constantly be asking you for things and be relentless around getting what they want when they want it. And that is where transference can set up in the relationship. And if you're a person who has difficulty understanding where to say no, then we almost take the place of the enabling parent by giving them more than what they may need in the treatment setting. So we have to remember that patients bring their everyday responses and distortions of life into the relationship with the counselor, doctor, or nurse. So the implications of transference in favoritism and bias, it's particularly activated when there's a difference in power. And we know in the therapeutic setting, in the therapeutic relationship, just by being the counselor, the doctor, or the nurse, we're carrying a lot of heavy weight and power with the patient. All of us also carry historical memories of childhood where we either had positive or negative experiences with illnesses from our patients. So if the patient has had difficulty with illness, they're going to have difficulty in the treatment center as they attempt their recovery. And unrecognized emotions can create powerful and unrealistic patient expectations and counselor responses. And oftentimes, that is the relationship that's going on for that patient that they've experienced in the past and now are using that because that's the only way they know how to interact with you as the counselor. Countertransference is a little bit different because now it's the counselor, and it refers to the range of reactions or responses the counselor has towards the patient based on the counselor's own background and personal issues. And as we've talked about before, we have counselors who are healthy, and we have counselors who may not be so healthy and or may have some personal stuff going on in their life and bringing that to the work setting, and then that affects the relationship between themselves and the patients that they see. If the counselor's own boundaries are not firm, then he or she is more likely to have difficulty remaining objective and may make poor clinical decision. So let's say that the counselor's needy, going through a lot of personal issues, feeling very vulnerable. And a patient who needs them desperately is something that would fulfill their needs. So oftentimes, they are going to give the patient whatever they need, regardless of the clinical justification for that. So that's how countertransference can affect the treatment milieu. There are implications for countertransference in favoritism and bias, and counselors really need to pay attention to their own feelings. They need to understand what's going on for them. And so again, as we've talked about in previous presentations, the role of supervision is critical. It's critical to understand what's going on with you and how you affect the relationship. Just as we talked about in the transference area, what's going on for the patient and what they bring to that counseling relationship. Counselors should also keep in mind that the feelings patient evokes in the counselors are likely to be feelings that the patients are evoking in daily interactions with others. Reactions to strong countertransference feelings end up that as counselors, you're going to try to respond to a patient's every wish and expectation, which is not healthy for the therapeutic relationship and getting a recovery foundation. Also, undertaking special tasks requested by the patient and feeling like they're the only one who understands the patient. And so in transference then, especially if a counselor is feeling needy, are feeling like, I'm the only person who can take care of this person. I'm the person who will be able to help this individual, more so from a basis of fulfilling their needs versus fulfilling the patient needs, which is why we're there. In-group favoritism is very interesting, and it starts with ancestors living in small social groups that were frequently in conflict with other groups. It was an evolutionary functional for them to view members of other groups as different. And so when we think about when we came to this country and were really invading in on the Native American population, we became very conflictual at that time and began to stay within our in-group, or the group that we belong to. When we think about immigration in New York City in the early 1900s, you know, New York City, like other cities, ended up having neighborhoods of similar ethnicities where people felt comfortable being with the people that they knew and understood. And so when you think about our patients coming into the treatment setting, they're going to look for people who are like them, and they're going to feel more comfortable when they're with someone who's similar to what they are. Also, you want to consider differentiating between us and them, and that probably helped us stay safe and free from disease, and as a result, the human brain became very efficient in making these decisions. So as we did it long ago, we continue to do it today. Anytime we go into an area where we're unfamiliar, we're going to be looking for someone who's close to being like us. And some of our treatment programs have been developed with a specialty of a particular culture, a particular sexual orientation, so that the individuals feel welcomed when they come in. So it's a very important piece in how we take a look at how our programs are set up. In-group favoritism then, though, where it goes awry, is a tendency to respond more positively from people in our in-groups than we do for people in our out-groups. So, for example, if I'm from Italian descent, if someone came in with Italian descent, I might feel like I understand them more than anyone else. And that I will be able to provide that kind of guidance as a counselor because we share the same heritage. So if that person may be breaking the rules or whatever, I might let it go because I know that kind of person and I understand who they are. So when we find people who are like us, then we begin to see where favoritism and bias begin to chip away at the therapeutic relationship. Causes of in-group favoritism. It's a natural part of our social categorization. We categorize into in-groups and out-groups because it helps us simplify and structure our environment. We are particularly likely to show in-group favoritism when we are threatened or otherwise worried about self-concept. And when we think about our patients coming into treatment, they're afraid. So they are going to cling to what's comfortable for them, what's familiar to them. But the most important determinant in group favoritism is simple self-enhancement. We want to feel good about ourselves, and seeing our in-groups positively helps us do so. So if you take a look at the in-group categorizations that we have within the treatment setting, it could be gender, it could be age, sexual orientation, those in recovery, culture, ethnicity, and religion. When we look at culture, there was a very interesting piece of literature out there, and the concept is known as the familiar face over generalization, or the FFO. It's strangers from one's own racial group are more familiar than strangers from another racial group, contributing to in-person favoritism. So if someone looks like us on the outside, we are going to feel more comfortable being with them when we come into the treatment setting. But we don't necessarily know what their racial origin is or their religious origin. So we're using just what somebody looks like. So perceivers use appearance features to make a racial or other categorization of an individual. So, what are some examples of favoritism that happen within the treatment setting? Many kinds of interactions can potentially interfere with the primary clinical relationship between the practitioner and the patient, and it poses concerns about acceptable conduct for healthcare professionals. So we might, if we are providing more favorite type behavior, is give someone more time and attention than we do anyone else. We might prioritize our scheduling appointments for them. In the more program type settings, you might overlook rule violations. And last but not least, you could do special tasks requested by the patient. And remember, if there's no clinical justification for any of these, because any of these could be something that you would do, but if there isn't clinical justification, then they just are examples of favoritism and bias.
So I want to touch a little bit on what you just went through, because I really like those examples, but I'd love to walk through them a little more and kind of speak to the impact of those, right? Because as we're talking about favoritism and bias, we've all had that one person who, for whatever reason you can't even explain, you identify with them, you have a soft spot in your heart for them, you know, just a general warm and fuzzy for someone for whatever reason. So the first thing you mentioned was giving a patient extra time or attention. And I know a lot of times when we talk about this, what we're speaking about is when an individual is in a treatment program, usually when I see it, unfortunately, is when it is progressed from a little extra attention to it's developed into an inappropriate relationship. So, you know, what effect would it have on a person who is favored if you are giving that person a little extra time? Why is it bad? In the very basic realm of things, why is it bad to do that?
I would say, and I hate to use the word bad, because there are times where we're going to have to spend time with our patients given the particular situation that they're going through. But if there's no particular reason, one of the things we need to ask ourselves is, why am I spending more time with this patient? Is it that I want to spend more time with that patient? Is it something that's going on for me? Is it some sort of interaction between the patient and myself that I'm liking and that I want more of? The other piece is, as we discuss these kinds of issues in the multidisciplinary team case conference, my colleagues might say something like, Maria, you're spending an awful lot of time with Joe. We don't understand why you're continuing to have sessions with him. He's not really doing what he needs to be doing in his groups. So when someone's not progressing in their recovery because we aren't allowing them to, then that's where things can go bad, basically.
Okay.
And I think
bad in quotes.
Yes, bad in quotes. But I think the other piece is, as team members in the programs, as you see that, it's very important to bring it up, because we had a particular situation where a counselor was spending an inordinate amount of time with a patient, and in the end there was an inappropriate relationship, and everyone kind of knew it but didn't say it. And so it's really important to address it either within the team, within individual supervision, and it may be nothing, but it may be something, and it's important then to get something early on before it becomes a larger problem.
So address it early, address it often to
Correct.
prevent from having to address a greater problem
Correct.
down the road. And what about, you know, I see things from the bookworm side of things, right? I'm the one who's reading the books, and you're the one who's got the boots on the ground, you're the one who sees it. So when we talk about, say we've got somebody who is a patient and they broke a rule, and the counselor, for whatever reason, because, you know, maybe they have a soft spot for this particular person, you know, maybe they like the same band. We'll go with that. That seems like a good bet. They like the same band. They have somehow identified they like the same band. So, you know, I know that you were out of bed later than you were supposed to, or I know that you were making a phone call when you weren't supposed to, or you've got contraband that you shouldn't have that's in theory not dangerous. I'll overlook it this time. Why is that a problem for the community? What's the impact on the community? How do the other patients respond to that? Have you seen that happen?
Yes, absolutely. Absolutely. Well, one, it makes the therapeutic environment unsafe. It also creates conflict because our patients will take a look at what's fair and what's not fair. So even in something that's not necessarily dangerous, people feel like not supported. They don't feel like you're interested necessarily in their recovery. They may choose to leave services against clinical advice. So it doesn't benefit recovery. It doesn't benefit the community learning recovery. It doesn't benefit the person in terms of understanding consequences of behavior and beginning to learn how to interact appropriately in environments, different environments. So there's a lot of reasons why it's problematic, and the fact that we have trouble saying no is our issue. And so we need to be able to address that in supervision. And or if you're a supervisor watching it, then that's the question you bring up in the supervisory session and have a discussion with the counselor around, it seems like you're having a hard time setting limits with patients. How can I help you do this? And once we understand that we're providing good, healthy care to our patients, it's easier for us to say no.
And then I'm going to ask one more question, and I think it'll lead into our next topic, which is cultural competency, which is, I think, a big part of all of this, right? It's understanding where we come from, understanding where our patients come from, and how they act and interact and react to us, or vice versa for us. So, we're talking a lot about favoritism. What about bias? We, always have the person we have a soft spot for in our life, and it may be work or it may be personal life, what have you. But what about the circumstances where you have a patient who, I'm going to make up a totally random example, comes to you, you're their counselor, and the bed sheets here are terrible. Mm-hmm. They're really bothering me. I really can't stand it. Mm-hmm. And the bias, for whatever reason, this person just rubs you the wrong way. You may not be comfortable with them, and it's an inherent issue in theory, or maybe it's something that you're aware of, hopefully not. And you kind of just, oh, they're just being silly, as opposed to maybe you'll look and see that there's like some defect with the sheets or something that's actually bothering them. Or maybe it's the food, or maybe they have a dietary restriction. So, what's the impact on them individually and on the group, the community, when you have those circumstances?
Well, as you're talking, one of the things that I'm thinking about that occurs, and we've been within the inpatient rehab realm, we have seen a lot of young adults who are opiate addicted, and they're coming from affluent neighborhoods. Something that I would say our counselors oftentimes worked with those individuals who were indigent, coming from poverty, not having much. So here we have this different population now, and there could be, I've seen, bias towards the spoiled person coming into treatment, wanting everything perfect. The sheets aren't right, the food's not right, we don't really like this program that much. And so our counselors then, rather than understanding where the patient is at that moment, will dismiss it as they're spoiled brats. They just want everything that perfect. They don't want to give in their recovery. They're never going to recover. So we begin to set up all this bias around this particular age group. And that doesn't become therapeutic to this person who's coming into treatment, who may need to work on what their immediate gratification needs are, because we know that that's indicative of the population, but that we've somehow taken bias now and made it an issue for treatment. The other thing it results in is our staff being nasty to patients because they feel like they're just privileged, and somebody needs to set them straight. So oftentimes our language then becomes harsher, and then there's an incident that we haven't been professional on our end. So I think that we have to remember that while young people have tendencies to want everything and want it now, we have to have a plan in place on how to deal with that and how to show that that behavior is going to help them in the recovery when they get out into the community and begin independence.
Now, I think we can both agree quite easily that we're usually speaking to the outliers here, right? So
yes,
absolutely. By far and large, most of our people, and I say our people as the world we live in, have that nurturing tendency, which can lead to favoritism. But I did want to at least touch on the bias part of it because, I did think that was an important part to cover. Okay, so with that, I think I'm going to shift over to cultural competency and what is as addiction professionals and licensed or credentialed professionals, what is our ethical obligation around cultural competence? So when I'm talking about cultural competence, I'm talking about recognizing the differences between how you were raised, your inherent culture, and that of the people that you're interacting with. Now, when we're talking about patients, this is actually really important because there may be something about a patient that you're not aware of, or if you're not if you're not culturally competent, you won't be aware of, such as, whether or not they make eye contact or, handshakes, anything which might be really normal to you, which could be abnormal or actually offensive to them. And that's, I think, why cultural competency is, for one, incredibly interesting and also very important. It's just recognizing the differences between you and others and learning how to practice in a way that's respectful of that. So one of the first things that I wanted to touch on was the 350-hour education and training curriculum. So this is the training that our CASACs and our CASAC-Ts use or go through as they're preparing to become CASACs and CASAC-Ts, CASAC applicants as well. So there's a couple of different segments to cultural competency. The first is a segment that focuses on special populations. So that could be individuals with sexual orientation, different sexual orientation, domestic violence, veteran status, different ethnicity or gender, religion. There may be people of different age groups. Another part of the standardized curriculum is the how can you talk to and understand and interact with people from across the different cultures that we interact with. America is very much a melting pot. New York is no different. We absolutely have a tremendous amount of diversity in the type of people and the different religions and ethnicities and genders and ages and races that we interact with on a daily basis. So it's increasingly important to understand your own cultural diversity, where you come from, and how that impacts your interaction with people, as well as your attitudes around cultural differences or others' attitudes around cultural differences. And then understanding how to make that work in your practice. So as a part of the 350-hour curriculum, I believe there's 15 hours that are specific to cultural competency. Okay. So I have included, and some of this might be repetitive because in the last session we actually talked about discrimination or the prohibition against discrimination, which does appear in several different credentialed ethics for different credentials as well as licenses. So in the CASAC Canon of Ethics, I did want to point to this because I think it is very closely related to bias and also cultural competency, which is just that there's a prohibition against discriminating when you are a CASAC or a CASAC-T based on someone's race, religion, age, gender, disability, many other factors. And I did also want to include the reference to respecting the integrity and protecting the welfare of the group or the individual patient, actually, even that you're working with as a counselor. I think that's probably one of the most important tenets of being a counselor in an OASAS program is protecting the individuals that you're working with. So the second item that I wanted to raise was the CPP or CPS Code of Ethical Conduct. And this is an OASAS code, again, but it speaks to the requirement or the prohibition against discrimination, but what it also speaks to is the need right there within your ethical code to understand and accept or broaden your understanding and your acceptance of cultural diversity and interacting with individuals who are different than you and making it so that you can provide services and information that's sensitive to those differences. So maybe you're not making too much eye contact with a person accidentally, or you're speaking to them and you're providing them information about their treatment or their treatment plan that's understandable to them and that's consistent with their culture. So the next item is the NASW, or National Association of Social Workers, definition of cultural competence. And I included this because I actually really like it. I think it provides really good insight into the importance of cultural competence and what it's all about. And that is the process by which individuals and systems respond respectfully and effectively to people of all cultures, languages, classes, races, ethnic backgrounds, etc. So the thing I like about this is it gets right to the point, right? So respectfully and effectively, because at the end of the day, that's what we're focused on with our patients, is how can we work with them, help them get to recovery effectively, and do it in a way that isn't going to be offensive to them, inadvertently offensive to them. And it also focuses very much on recognizing, affirming, and valuing the worth of individuals, families, and communities, and protecting and preserving the dignity of each. So I just wanted to share that with you because I did find it to be very important. So in addition to the definition of cultural competence, I also wanted to include the Social Worker Code of Ethics. Now I will say, I have included a couple of different snippets from some of the licensures' Code of Ethics. These are absolutely not the only ones that matter. There are absolutely more licenses that are not covered, but I did want to include a couple of examples. So for the social workers' ethical responsibilities to clients, 1.5 is for cultural competence and social diversity. And in a very summarized nutshell, it's understanding the function of culture, and understanding your individual client's culture. Obviously, if you know something about where that client is coming from, you're going to be able to more effectively respond to them, as well as educating yourself. And it's not just understanding that there are differences, but understanding those differences and how they come to play in your interaction with them, their interaction with you, for any number of different diverse populations. Okay. So I think there's two more codes. There's the Mental Health Counselors Code of Ethics, and that's the AMHC Ace, or American Mental Health Counselors Association. And this is the Counselor Responsibility and Integrity section. And this specifically speaks to competence and recognizing the need to be competent about cultural diversity. And then actively working to understand the different cultural backgrounds of your clients and how they work with you, how you work with them, etc. And then, of course, a prohibition against discrimination, which I'm not going to cover as much here because we covered it in our last session. Okay. So the last credential, which is more prevalent and getting more prevalent, I think, by the day in our field, is the Serpa, which is a Certified Peer Recovery Advocate, and these are their professional standards. So I included just the prohibition against discrimination based on race, color, sex, sexual orientation, age, religion, etc. But what I did want to show for all of these was just the requirement that we all inherently have in our practice as addiction professionals to be culturally competent, be aware of where we came from, where our clients came from, and how we can be better responsive to our clients by being aware of how their culture impacts their road to recovery. So with that, I'm actually going to turn it over to my co-host, Maria.
Thank you. And really it all begins with us as counselors, as doctors, as nurses. We have to set the stage for making sure that our practices are competent and fair. So oftentimes our patients may need more than what we can provide them in the clinical setting. And it's not always appropriate for us to provide them help in other ways. Our goal is to help our patients become independent. We have to empower them by giving them tasks to do within their recovery versus taking care of them in recovery. And we have to remember that every action that we have must not adversely affect the relationship between yourself and the patient. It may not affect adversely the patient or compromise the care of other patients that are in the program along with you. We have some recommendations to create a positive work environment where we begin to question ourselves and we could question our colleagues. So I have 4 questions for you. First, to ask yourself, is this activity normal? Is it expected part of the practice for members of my profession? Could this activity cause others to question my professional objectivity? Might engaging in this activity compromise my relationship with the patient, with other patients, with my colleagues, with OASAS, and/or with the public? So in doing that self-exploration, hopefully we can come to the conclusion whether or not the action we'd like to take with a particular client is something that is ethical and fair. So, some next steps for you. Review your policies and procedures to ensure whether the activity identified is an acceptable practice. For example, sometimes we have programs that provide transportation to the next level of care. Some do not. Does that mean you as the counselor hops in the car, brings the client with you, or does that mean you set up a particular transportation that you utilize other modes? So that's where things can go in a problematic way if we take care of the situation. So check your policies and procedures, find out what you're doing to make sure that it's within acceptable practices. Seek assistance through clinical supervision. Can't emphasize that enough, and I'll be saying it in every month that we talk about, and how important the time that you spend with your counselors is the proactive approach towards making your environment an ethical environment. I also encourage setting up an ethics committee where you can identify some people who can help decide whether or not an action is ethical or not. Also, consultation with a trusted peer or discussion in the multidisciplinary meeting for a second opinion. As members of a multidisciplinary team, if you're seeing something that you think is not right, speak up. This is your time and opportunity to make your opinion known and maybe stop something that is going way beyond what we're supposed to be providing for our patients. And then communicate the concern to the individual involved, as I said. Make sure that you speak to somebody. In summary, we should guide our patients in doing the difficult interpersonal tasks themselves. We want to strengthen their ability to take responsibility for their lives. We want to teach them how to maintain appropriate and important adult boundaries. It's also important for us to remain calm, optimistic, and recognizing that getting overly involved will deprive your patient from having the opportunity to learn something. And we know when we've learned something on our own, it is the best learning versus someone teaching us something. Counselors need to be aware of how they're perceived by patients and that some of their own attitudes may contribute to favoritism and bias. So I want to thank all of you for being part of this presentation today. You'll see we have a list of references that you can find if you want further readings in what we presented today.
I'd like to thank Tricia and Maria for this presentation. We welcome your feedback. It lets us know if we are meeting the educational goals and expectations of the field. Once you have viewed the presentation in its entirety and completed the quiz, please follow the directions to access the SurveyMonkey link to complete the evaluation. Thank you for joining us and enjoy your day.